We have a relatively full agenda, so I'll try and keep us at pace as we go through it. The meeting is being recorded so that you're aware of it. We received several apologies. So in terms of voting members, Lisa Nopes has sent apologies, but we have Karen Watts and Howard Martin sent apologies, but we have James Granger here, so we are quorate for the meeting. Also, I don't expect Ian Wake to join, and we received apologies from Peter Taylor and Sally Watson. That's what I have on my list. There's no chair actions for me to report on. So I'll go to item 3 on the agenda, which is the declarations of interest. Does anyone need to highlight an interest in view of today's agenda? No, that's good news. That takes us to the next item, the review of the minutes of the last meeting. I'll take them in their entirety. So are there any comments as to accuracy of those minutes? No, that's again good news. Many thanks, Sarah, for those minutes. We go to the action log. As you can see on page 14 of the pack, 3 are close to the reasons outlined, and action 214 will come to the dentistry risk later on, but that's been clarified, so I think we can close that item as well. And the last one is not yet due, so we don't need to worry too much about that. So that's all going smoothly. Takes us to item 5, the forward planner, which is in your pack as well. And I'll invite Sadie to see if there's anything she wants to highlight from the forward planner. I'm conscious there's one more meeting to go on that one. So
nothing to highlight specifically on there, Hein. You'll see that there's a red N for the Pharmaceutical Services Regulation Committee, and that's all down to timing, really. But no, nothing else.
All right. I see no hands up, so we have noted that. We stay with you, Sadie, for item 6, or the introduction for item 6 on the risk register. So can I hand over to you?
Yes, thank you. And apologies, I am in the office, so if there's any background noise, I hope you can hear me okay. So this report, I think what I'll do is I'll focus on the changes, if that's okay. So, and they're set out in the section key highlights since the last meeting. So there has been a deep dive of the 2 workforce risks, and they are covered later in the workforce item on the agenda. So, Chair, if you're happy with that, I think probably better to deal with those later on the agenda. But really good piece of work to refine and review the risks there. The dental risk, I will shortly ask Fiona to talk to, but essentially following our programme of deep dives, we have reviewed and reframed that dental risk as per previous discussions. And we're proposing a revised risk with revised scoring to the committee. The community pharmacy resilience risk, we met yesterday to have a deep dive on that, and Sharon and her team are currently working on that, and we will bring it to the next committee meeting in March. Again, that's reframing the risk through a patient lens, and then scoring again based on all the actions that we've been taking. The SMI risk, that happened last week. I'm hoping Shepherd can update on that in a moment before we move to Fiona. And the general practice risk, again, we aim to bring that back in March. The deep dive review meeting is yet to take place, but that is programmed in. So if I can hand to Shepherd to say a few words on SMI before we go to Fiona for the dental risk. Hein, thank you.
Thanks, Shepherd.
Thank you. Apologies for the mix-up for the deep dive dates there. You can see that the community pharmacy, it says 19th of January. It was supposed to be the 12th, so it's the other way around. So the SMI is the one that we're going to hold on the 19th. Apologies for that mix-up. But we are doing reasonably well in terms of our performance for SMI, but more details will be covered on the 19th. I think that's far I would want to go on that.
Yeah. All right. Good. So before we bring Fiona in on the sort of newly framed dentistry risk, any questions or comments from committee members on the other risks Sadie alluded to? And as Sadie suggested, we'll do the workforce deep dive reflections a bit later on. I see no hands up, so Fiona, can I hand over to you on the dentistry risk?
Thank you. So as Sadie's alluded to, we've had a deep dive on looking at the dental risk. As you'll be aware, we are responsible for primary care, community care, and secondary care. And in the past, there have been 3 separate risks, but actually the service provision and the impact of one service on another is so integral that actually it makes more sense to have one single risk. And also that supports the left shift from secondary care into community. We have tried to look at it from a population and patient perspective. So what are the risks if those services don't exist? And the paper sets out how what approach we've taken, but also looking at how we can measure a success. And those are really aligned basically to our commissioning intentions. So hopefully everything aligns in how we address our approach to commissioning contracting services in the future. We've reassessed the risk. We believe that an unmitigated risk score would be at 20, where the likelihood is 5 and the consequence is 4. But I think with all the work that's been done across commissioning, contracting, quality and workforce, we believe that the mitigated risk score currently stands at 16. I think everyone appreciates that this is not something we're going to solve quickly, but also there are a number of areas which are outside our control. So therefore we've set the target risk score at 12. I think, and then what we've tried to do is to set out the controls and the mitigating actions, but those are much more high level than previous mitigating actions. And that's to reflect, I think, the more strategic approach and more patient aligned focus on looking at risks going forward. But I'm happy to take any questions.
Thank you, Fiona. I really enjoyed reading the risk and the exercise you and colleagues have been through, so compliments to everyone involved on that one. Let me open up for questions and comments. Nick, you have your hand up.
Yeah, just a couple of queries over the bullet points of measuring success. I think the first bullet point suggests a reduced underperformance level would actually, in other words, less dentists underperforming would be approved or seen as a success. But actually, with the ICB being able to unilaterally rebase dental contracts, there's a chance that actually a lot of contracts will be rebased, and the dentists will then be hitting their targets, but actually the number of UDAs being delivered will be vastly reduced. In other words, it wouldn't necessarily be seen as a success, even though that less dentists were underperforming. It might be because they've been rebasing contracts. So I think that's something to be careful about, that we don't use that too carefully. The other one is bullet point 4, which is an increase in workforce numbers. Now, I think that probably should be prefaced with the whole time equivalent, because a lot of dentists these days are being taken on as part-timers, and actually you often find that although we seem to have an increased workforce, and certainly the number of dentists registered with the GDC is at its highest level ever, but the amount of actual hours being worked by those dentists is lower than it has been for a very long time. In other words, there's a lot of part-time dentistry taking place. So I think those are 2 bullet points we need to be a little careful that we don't apply too carefully with over measuring success.
Thanks, Nick. Any immediate comments, Fiona?
Nick, thank you. No, I think those are really, really good points. I guess the reduced underperformance levels actually relates to a national operation planning metric that we have, which is to improve the delivery of UDAs. And actually, we're doing really well on that. We've gone from 63% in 23-24 to 74% in last financial year, and we're on target to deliver 76%. But I do take your point. I guess that where we are rebasing contracts, we will of course be reinvesting that money so that we're making good use of public funds to improve access where we can, with practices or through new contracts, which will deliver. And I think, yes, your point about the workforce numbers is really helpful, and something, yeah, we'll take away and have a look at. Thank you.
Thank you, Nick. Any other comments or questions? Shepard. You're on mute, Shepard.
Yes. Fun. It's not a question, but it's just an appreciation of the focus on patients, especially with the last bullet points in terms of looking at bringing the voice of patients at every opportunity, looking at the complaints and also increasing the access for patients. And I think that really reflects what we want. So thank you for including those ones.
Thanks, Shepard. All right, so as per usual, we're asked to approve everything in the risk register, but that includes specifically this new dentistry risk, but also any other risk that you have seen in the pre-read. So is the committee happy to approve the risks, not just this dentistry risk, the overall risk register assessment? I see nods, so that's approved. Many thanks, Sadie and Fiona. We move to item 7, Director of Primary Care report. Sadie, can I hand over to you?
Thank you, Hein, and thank you, Amanda, for drafting the report. I think it's obviously quite a comprehensive report there, and I'm going to take the paper as read. I think what you see throughout is the operational delivery of the teams versus kind of the movement towards strategic commissioning, in line with the ICB blueprint. So
you're on mute all of a sudden. I can't hear you. And I can't lip read, so.
Can you hear me now?
Yes.
That's very weird. I do apologize because I'm nowhere near my mute button. So day to day, that translates at the moment into the team spending a significant amount of time on planning in response, and it won't be any different in any other team in the ICB. So planning requirements, financial planning for next year and beyond. We also have a significant number of procurements across dentistry and general practice at the moment, which is taking a significant amount of time. At the same time, we're looking forwards. Contract reform is something that is coming for both general practice, dentistry, community pharmacy, and we expect optometry to become more clinical in future in the same way that pharmacy has. so that's a big feature for us, and as well as the work that we're doing to try and lay the foundations for primary care as part of our system in the future as a resilient partner, resilient provider, and that's all of primary care that we're focusing on there as part of the structured approach to neighbourhood care development and a new model of neighbourhood care. And of course, we've previously touched on the work that we're trying to do to support development of primary care collaboratives across Norfolk and Waveney, which I know kind of Amanda will probably touch on more later in the agenda. And all of this is really in a context of quite significant change for staff. The organisational change programme, as we know, is ongoing, reaching conclusion in the very near future. You know, we do have some concerns about the risks attached to all of that, especially sort of capacity as people start to leave the organisation and the loss of organisational memory, as well as it being really unsettling for the people that remain while the new structure is filled. So I just wanted to acknowledge the impact of that and really appreciate all the work that the team continues to deliver, to push through on at a time of significant change. So I think that's probably all I would draw out from the report, but very happy to hear any comments, take any questions, and I think Amanda is probably included in the report, if I remember rightly, that we're also very keen to hear what you might want to hear in the future as well.
Thanks, Sadie. Mark, anything you want to add at this point?
Thank you. No, just to echo kind of some of Sadie's points, really, and a big thank you to you as well, Sadie, as the wider team. It is a difficult time. I know all of you on this call know that for staff. We're used to change in the NHS and across the NHS, but this is quite unlike anything we've seen before. However, what I'm really pleased to see, and I think we can see it from the report today, that we are making improvements. We know we've identified some of the risks, and we know that there's things that we need to do further work on, but we are seeing demonstrable improvement for ultimately our patients across Norfolk, across all of the specialties in the primary care arena. So I know that's down to many people on this call who work within and support the ICB. So just an additional thank you from me. Thanks, Hein.
Thanks, Mark. So let's open for question, comments, and Ian, you have your hand up.
Thanks, Hein. I won't labour the point, but absolutely in agreement with Mark. That was going to be part of my comment. The other part is really a question around some of the content of the paper. On page 2, it talks about primary care contractor development being a major priority, and expert support has been secured to strengthen capability. Can either yourself, Sadie, or yourself, Amanda, just add some further meat to the bones on that, because we were unsure what that was referring to.
Good, Sadie.
I can see Amanda's put her hand up.
I think that's work that hasn't been finalised, the content of that yet, Ian. But I don't know if it's helpful to emphasise that this is in terms of neighbourhood health development, particularly we're talking about. So we're talking about things that sit outside perhaps core contract delivery, the national delivery, and that space, which is all still a bit unknown to us all yet. Yeah. We're all still waiting for lots of details, and it's the preparation and making sure that we work with our leaders across primary care so that we can start to have a shared or have more of a shared understanding of our starting point and where we're going to get to, so that when we embark on that journey, as the details come out, hopefully that will make it a better journey with better outcomes for everybody.
Okay, thank you. So when you say that expert support has been secured, that's what outline support or in a particular area to do with neighbourhoods?
So we have secured some funding that's gone through triple lock and all the other governance procedures to pay for some expert facilitation from a third party that have got experience elsewhere in the country, that kind of thing, to guide us through this.
Yeah, thank you.
If I can build on that, because I had a similar question to Ian around these workshops, and I know there's been some delay in the national organization publishing neighborhood care guidance.
Yeah.
So is there sort of an updated time frame within which there's more clarity provided, so there's a bit more meat on the bones? Mark, do you happen to know?
So is there further updates? So I know the deadlines for when we are supposed to expect to deliver our plans, and of course the county council will be taking the lead on much of this, which is ultimately April is the deadline for us for that. But we're told it's imminent in terms of that further guidance. We had an update to the blueprint that was the ICB blueprint that was shared, and it was very high level detail, awaiting further guidance. So unfortunately, we can't share any further details because we don't have it. I mean, there are rumours. Will it be delayed because we're waiting for some of the guidance? But I don't think we as a system should wait. I think the core elements of neighbourhood and neighbourhood delivery we know, and I can't envisage that the new guidance will be a dramatic U-turn or a change of course. And so we're planning on that basis.
Yeah. Okay. Thanks. I see no further hands, and again to your point, say there's an enormous amount of change coming in a very short space of time. So my appreciation to you and colleagues for managing through that. And we may touch upon some of this when talk later on strategic framework. We go to item 8, primary care operational plan update. Amanda, I think you will introduce that.
Thank you, Hein. Again, I'll take the paper as read on this one. So the first submission was made and we received some feedback from NHSE, I think towards the end of last week. They do that in the form of key lines of inquiry. And for primary care, those key lines of inquiry that we'll be working together on over the next couple of weeks are around the numbers of appointments in general practice, the number of pharmacy first consultations, and the number, I think, of urgent dental appointments. Quite a lot of the questions have a degree of technical work involved, not all of which I claim to understand, but I've got colleagues like Fiona and Sharon that can help with all of that. I think that's quite normal. There is always a bit of toing and froing about where the targets are. Are they stretched enough versus are they realistic? And I think some of that comes down to population growth, where people expect us as national level to be in terms of productivity gains, and that need to balance where perhaps there's been a national number attached to an increase, and where that comes down to fair shares. Sometimes there's negotiation around where we are as a baseline. They're the type of conversations that I think we can all expect over the next couple of weeks. The next submission date is due on the 12th of February, and I believe there'll be a board meeting convened to make sure that goes through the governance process. And the figures, when they're all done and they're part of that plan, we would share those with the voting members. But they are because they are Norfolk and Suffolk, they look very different, and we can't sort of chunk off our Norfolk and Waveney part to look at them, because going forward from the 1st of April, when we deliver against those figures, we will be one team, we will be one ICB. So will be assessed on that. So that's where they are. There's a bit of work to do with the final planning submission to make sure that that cross-references as it should do with the emerging ICB strategy, which I think is coming to board in January, and the population health improvement plan. Those together with our commissioning intentions and our operational plan, that's what the work plan for the primary care team for Norfolk and Suffolk will fall out of. And that's what I guess will come here and be monitored through this committee next year.
Yeah, very clear, Amanda. Many thanks. So this is really a status update where things are at the moment. Any questions or comments for Amanda? Lisa.
Thank you, Hein. Thank you, Amanda. There's just a couple of points. It says within the report, achieving consensus on these elements will require constructive dialogue, both internally and within HSE colleagues. Will the LMC be part of this constructive dialogue as the main representative for general practice? Also, there needs to be assurance that harmonised does not mean adoption of what may be in place for either Norfolk and Waveney or Suffolk across the entire geographic, as it is essential that the flexibility is maintained to meet the local specific needs, because they can be quite different. The planning needs to consider that general practice is already working beyond what is reasonable, where many practices are reporting staff burnout and demand continuously outstripping capacity. The ICB needs to be realistic and informed of capacity, as there are significant restraints on capacity in general practice across the entire region, and this is a concern that is continuously being reported through GPAS. Thank you.
So I'm sure we'll continue to talk about that at our regular meetings as we have done all along. And I think these are very high level numbers. These are the total numbers of appointments in general practice. And they're the things that come through on the GP dashboard. So I don't think we'll see any impact from combining with Suffolk. It'll just be that they're bigger numbers.
Thank you.
Okay, I think Lisa raised a few other points, but I think that the point here is it's not just about the numbers that get submitted, which tend to get a lot of attention, but it's also about sort of the how we deliver, and I think that's underpinning some of the points you raised, Lisa. So I think these are points well made. Thank you. I see no further hands up, so many thanks, Amanda, for that. We move to item 9, the GP Action Plan report. Shepherd, you will guide us through that.
Yeah, thank you. And you've got a very detailed report on progress on where we are with the GP Action Plan. But I'll probably say a few kind of background points just to kind of refresh the committee on this journey. So you may recall that the committee signed the GP Action Plan back sometime last year. And since then, we've been working closely with NHS England colleagues to continue to deliver this with some special interest from NHS England in certain areas. But what I have observed is we set out a very ambitious action plan at the beginning, and it was at that time when we did it. And we set out about 15 priorities in that, which is quite a huge list to concentrate on with the limited number of staff. So you can only imagine that, albeit we've done well, but it comes with a lot of pain in that. So the action plan is split into some strategic priorities, and that is around improving the contract oversight, then the commissioning and transformation, and tackling health inequalities. So what I'm looking for today from the committee is to note the progress that has taken place, and also approval or support to close some of the actions that we think we have reached that point. So if allowed, I would probably want to focus in the first instance on actions that I would like support to close. Then if time allows, then I would like to highlight some of the work that is happening. So in the first strategic priority, which is around contract oversight, I think you've got 3 or 4 priorities sitting there. The first priority was around the work on PCAP, which was the Primary Care Access Recovery Plan. We set out that as an area of interest at the beginning, with the expectation that there will be further national guidance for us to proceed with that piece of work. But that position has changed. There's no further guidance that is coming through. And most of the work or the priorities that were expected or that were set in the last 2 years are well covered in the other priority areas and also in our usual day-to-day work, as you will see. And I think it's fair to say the pickup was focusing on unwarranted variation, increasing access, appointment, and patient experience. And this is a constant topic of interest for all our work. We're spending more time in doing that. So if the committee is satisfied, I would like us to close that that part of the action plan. Then the second,
Sorry,
shall I pause? Shall I stop?
Yeah.
Okay.
Why don't we take Karen's question, Karen?
Thanks, Shepherd. It's really helpful to go through this. So in terms of patient experience, what's been gathered? What have the patients actually said this is better for us? Is what I'm looking for in terms of an outcome. So when we say we're looking at patient experience, what are they telling us?
We are using so many data sources, and our position is improving year on year. What we are doing in terms of connecting to the population through the PPGs, through the GP patient surveys, I think we presented a report to the delivery group which showed really a positive trend in terms of patient access and experience. And we are introducing and strengthening our pharmacy first, and the level of activity is growing and growing. And you would see in our GP data, we are seeing more patients than we've ever done. And also in other clinical priorities, you would see our learning disabilities, annual health checks, we're seeing more and more people that. So all our data sources are pointing towards the positive future than where we were before. But you will see that patient experience will remain our focus in all our work, and it's something that we would want to be challenged on more and more. And I think you've seen the way we are framing the risk as well. It's focusing on patients, so we'll be able to gather more and more feedback on patients. So it's a continuous improvement journey that we are embarking on when it comes to patient experience.
Thank you, and thank you for raising the question, Karen. Andrew, you have raised your hand.
Yeah, thanks. Just to contribute the HealthWatch angle. So I get to read about 300 comments from primary care from patients every quarter. And to give a very quick overview, I'd say that the comments about access are improving quite markedly from, let's say, a year ago. But the comments then about once people are seen, they're quite happy with the individual clinicians that they see. But the main area of problems is with systems in terms of booking, getting appointments, coordination with secondary care appears to be awful. So people get lost in a complete web of being unable to find out about results appointments from secondary care and how it coordinates with primary care. And I know I've said this 1,000 times, and the problems with continuity, people really, really, really want to be seen by the same clinician, be it doctor, nurse, PA, whoever, as much as possible. And that I've seen again and again in all our papers doesn't get mentioned. So I really encourage you to perhaps, if you can, focus on the continuity aspect. Thanks.
Thanks, Andrew. I think these are also helpful points as the risk gets updated in the months ahead, as we heard. So, and I've seen Shepard taking notes as you were speaking. Ian.
Thanks, Hein. Andrew, you're absolutely right. Continuity is one of those utopia situations that the public certainly want, and indeed most GPs and clinicians want. The problem being that the national contract changes actually work against that. They are counterproductive, means more GPs are spending more time away from face-to-face appointments, doing admin and triage of these urgent issues that are raised by patients. And that sadly is the reality of what the contract changes have made. You're absolutely right that the public want it, the clinicians want it, the GPs want it. It was just the ill thought out contract changes that have meant that it's had a real detrimental effect over the last 3 months. But hopefully there will be change coming in the new contract.
See you. Back to you, Shepard.
Thank you. So the next priority that I'm seeking your support to bring to close in the action plan, it's in relation to enhanced access, which is really designed to improve the access for patients and also experience. What we set out in the action plan was to have a system of monitoring the activity and also the utilization. And my colleague Stuart White has done a fantastic piece of work to get to an agreement with LMC colleagues on behalf of practices to agree a reasonable approach to collect that data with a view to support PCN's colleagues that may be struggling with that. On the main, I think we are really doing well. We are receiving the data from PCNs. There's 1 or 2 PCNs that are requiring a little bit of support to make sure that their system is working well. So I think we've completed that task, and this will be reported as part of the normal contract monitoring through the delivery groups and other processes that we set up. If that's weird. So that is that on the contract oversight. So I still have other 2 recommendations sitting in different places. The next recommendation is around in the improving commissioning and transformation. NHS England was running a program to support ICBs to assess their capability around commissioning and transformation. And it was a voluntary self-assessment, which was facilitated by NHS England, and we agreed, led by Amanda Sears, to take part in that. So we set it as part of the action plan to carry out a commissioning and transformation self-assessment. And that piece of work has been completed over 2 sessions, and we're really pleased that we were able to bring all members of the MDT into the process to assess our capability. And we've come up with priorities for us to focus on. And for the purpose of this action plan, we have completed that, but we've got some work to continue in the new organization, harmonizing with Suffolk. We've already shared our action plans. We are aware of what Suffolk are working on, and they are also aware on what we are working on. And there's really huge benefit in that. So for the purpose of this action plan, I'm recommending that that is closed. If I move to the other 2 remaining, the other priority was around the development of the strategic framework, which was led by my colleague Amanda here, and really fantastic piece of work in terms of thinking about how do we amplify the voice of primary care within our governance structures, looking at the demand and capacity pieces of work, and again, looking at those long-term strategic commissioning thinking around at-scale developments, and again, issues around access and addressing health inequalities. And that piece of work is at that point we think we've done everything we need in terms of the documents, but this will be a live document that will be used to drive the transformation for the future. But for the action plan, we are recommending that this document can be, this action or priority can be closed. The final, if I can find it. Apologies, I just need to find the last recommendation that I've been asked to. If not, then I would refer to the document to say, I'm not sure, I can't find I thought I had 4 recommendations to make here for closure, but I can't find it.
Is it enhanced access or?
Yeah, it's the enhanced access, then the pickup, then the cuts too, then the strategic framework. Yeah, I've got the 4. Okay, thank you. Found them. So thank you. Those are the 4, but they're really important pieces of work that colleagues and the MDT are working on. So if I can just signal around the advice and guidance, that's a key piece of work in terms of capacity and demand management that is going on. We are not recommending closure for that item, partly because we think there's more that we need to do in terms of driving up the level of activity, given the recent announcement around some flexibility from NHSE. So we think we can do more. And I think we just need that benefit to spend more time to work on that. If I can make maybe one more point, I think it will be the level of interest from NHSE in this action plan. We've spent a lot of time looking at unwarranted variation, trying to look at the differences in different places around access and stuff, and that piece of work continues. We have done well against the baseline that we set, but this is a continuous process. So most of the practices that were in the initial data set have now improved, but we are continuously reviewing and supporting practices. So that area, I would like to recommend that we keep it and continue to work with practices and NHS England to understand more in terms of data and also support for practices and patients. I'll probably stop there, but really great piece of work from the wider team and colleagues leading on different parts of it, which is really exciting. It has brought a lot of focus and intentional kind of approaches to different aspects for delivering safe patient services. Thank you.
Thanks, Shepherd. Let's invite questions, comments. Karen.
Thanks, Shepherd. This has been really helpful and really pleasing to see. I guess when you mentioned continuous, it's a continuous process and continuous improvement. I think the one thing to remember is it needs to be sustainable. So where you have made those improvements, we really need to be in a position where it is sustainable, that we don't slip backwards as we move forwards. Thank you.
Thanks, Karen. Lisa.
Thank you, Shepherd. Thank you, Hein. Just a couple of points. Could you just confirm with me the part within the General Practice Improvement Programme? It says that there's been 31 practices that have participated to date, and you wish to increase this to 49 by the end of Q4 2026. Is that this March, the 31st of March this year, or is that the 31st of March 26-27?
End of March this month, this financial year.
That may be somewhat ambitious to get another 18 with the current climate as it is, with practices struggling with capacity, etc., to get another 18 in the next 2 months. Another point is the practice visit programme. We understand this is really data focused, and that informs the initial conversations and the initial plan when you go out to the practices. Rather than working solely focusing on tackling identified variation as a system, we should be looking at proactively supporting all practices, and this would be further enhanced through more sharing of trends and examples of good working practices identified through the practice visit programme. So there's a learning that can then be shared across the wider system. So examples where a practice is really doing well, that supports a practice that isn't doing so well. Is that something that could be considered and looked at going forward, please? Thank you.
If I may react to that, it's all good point, Lisa, and really good points. To respond to the first around the GP program, I think we are there already. I think the reports are sometimes written at a point in time, but I'm assured by my colleagues that we have done so well and we'll be able to meet that. And we are also looking to expand that at every opportunity if we can get, because of the feedback that we are getting from practices is, if it's fully supported, it's beneficial for practices and for patients ultimately. So, and I'm happy to pick this out, Lisa, because I think this is a great piece of work that if we work together as a system, we can deliver more for patients. Regarding the practice visit, I think the biggest outcome that we are looking for with the practice visit, it's not about data. Data is just an enabler for us, but what we are looking for is really to strengthen the strong relationships with practice. And the feedback I'm getting is that we want to create a space where practices feel comfortable, feel they're part of it, and they feel supported by us. So if there is any feedback or any visit that we have done and the feedback has been that is data focused, I don't think we would have achieved what we are looking for, because that's not what we've set out to do. So happy to have discussions to reflect on that, because I think we really need to get it right, because this is about people, not really about data. Data is there to help us so that we are not too general. Yeah, so those are probably the two comments I would want to make. But of course, Lisa, we work closely so we can get into more details around this outside.
Thanks, Lisa. Thanks, Mark. Thanks, Shepherd. Mark, you have your hand up.
Yes, thank you. And Lisa, I think Shepherd's covered what I was going to say. The intention is that they are helpful for all, but primarily for practices. It was intended to be a two-way conversation rather than a one-way conversation. So please, yeah, any suggestions, as Shepherd has highlighted, about how we can develop those to be even more helpful for colleagues, we're very keen to hear. So thank you.
Thanks. So in the recommendations in the note to the committee, it mentions several things, including that we approve closure of PCAR at Enhanced Access and Strategic Framework for the reasons Shepherd has guided us through. So I just want to make sure committee's happy with the closure of those items. I see nods and no dissent, so that's approved, and the rest is noting. So very helpful update, Shepherd, and many thanks for that. It takes us to item 10, workforce. Jade has joined us, as has Helen. So I think, Jade, I hand over to you for an introduction.
Yes, thank you, Hein. I'll take the paper as read. I'll just cover a couple of bullet points, if I may. So hopefully the paper outlines the actual strong progress we've made in strengthening general practice, dental and optometry workforce across Norfolk and Waveney. And Helen would obviously be focusing on her update in terms of pharmacy. The other elements I wanted to highlight is 40% of our programs have actually fully met their KPIs, with another 40% progressing on track. 3.3 million investment has been expanded in terms of training capacity, workforce intentions and initiatives across the area. When I wrote the paper, I was really delighted to announce that we were third nationally for GP workforce, but I am delighted to say we are now second in the country, rather than third. So we've moved up. I'm going for that gold place, but hopefully we've got silver at the moment. But anyway, but across the east of England, where we've got first place position in terms of positive workforce variation. The other exciting thing is, even though it's a very small increment, we've actually had our first increase in dental workforce since 2019, which we're delighted about, particularly and that is for dentists, that the workforce number is reported on. And actually, we've made really good progress in terms of our optometry engagement with our practices, and actually 50% of our schemes have actually been taken up, which is really, really encouraging in comparison to the previous years. 96% of our general practices are now an approved learning organisation. So, and that's increased also educator capacity. So that means effectively more medical placements are now coming across Norfolk and Waveney. Our new workforce dashboard is really providing a lot of that real-time data, looking at that stronger planning, looking at that strategic focus of what our programs are achieving and where we can actually focus our resources and intention. The other really good development is obviously in our non-clinical workforce development. Our volunteer integration and particularly around digital engagement are really showing quite strong uptake across all our practices. The challenges remain is obviously the organisational change is one of the key elements, but also continuous professional development capacity pressures, particularly around staff being released, and also taking up the offers is still presenting quite a challenge, as well as looking at our physician associate workforce uncertainty. Again, that is presenting more of a challenge within general practice, as well as actually in our acute providers as well. The other element I wanted to highlight is obviously the paper is to note those achievements, but also it's also to approve the actual mitigations and the success that we've actually brought in terms of the workforce risks for workforce risks 54 and 55. They're now I am pleased to say they're now actually falling within the risk appetite. And one of the elements I wanted to obviously seek approval from today is actually to agree to close risk of 54 and 55 for workforce because they have met their target risk scores. And that's it for me today.
Thank you, Jade. And I think, Helen, you will...
Yeah, would you want to take questions for Jade first, or would you like me to do and then round up?
Let's hear your bit, and so Lisa, I'll come back to you in a moment, but let's hear from Helen first, and then we'll open up for wider questions.
Thank you very much. Again, I shall take my paper as read, just with a few highlights in that the team has made steady progress across our attract, train, retain and reform work streams. Notable achievements over the past year is that we now have up to 39 foundation trainee pharmacist placements across Norfolk and Waveney, up from 20 a few years ago. They're planned for 26-27. And we also have an expansion of our teach and treat training programme for community pharmacy independent prescribing, which we have just been really highly successful in gaining another 9 students places across the combined area of Norfolk and Suffolk. And this is both of these things are helping us to prepare the primary care arena for pharmacists to be prescribing as routine activity. And we've also strengthened our working relationship with UEA and increased our presence at careers events to promote pharmacy roles to local students. And those events are very well engaged and attended. So as a team, we're still facing some significant pressures. So access to national training pathways can remain challenging, often with very tight application windows. And we also need to improve training placement capacity across the area and fix fragmented workforce data, which makes it very difficult to start planning and thinking about the pharmacy system as a whole. Similarly, as noted in the primary care workforce report, resistance to change and supportive learner activity is a barrier. Looking ahead into next year, we're starting to align our workforce activity across Norfolk and Waveney and Suffolk, but we do have proposed reductions in workforce capacity, which will need careful consideration into the next year as to what will be able to be delivered. Primary care pathways for community pharmacy prescribing will also need consideration because more people are being trained as prescribers, and if they don't have the opportunity to use those training opportunities, they will go elsewhere where they can do, either to other sectors and to other areas. But for now, the committee is just now asked to note progress and our proposed next steps for 26-27.
Many thanks, Helen. So we'll open up for questions and comments. There's a couple of hands up. First, Lisa, and then Karen.
Thank you, Hein. It's really good and really positive about the good work that's being done by the primary care workforce team. General practice is still reporting difficulties in recruitment and retention of both clinical and non-clinical staff. This is due to many factors, which include availability of staff. In many cases, it's the location of the practice being very rural with minimal transport links. And one of the things we're getting continuously fed back, specifically with non-clinical, is the abuse from the general public, and then obviously finances. This data is all continuously being reported weekly on GPAS, so it is shared. Therefore, it is essential that we do continuously monitor retention and capacity within general practice, because if we can't maintain the staffing levels, obviously that will have a further significant impact on capacity that is available. Thank you.
Thank you, Lisa. I think your message is no room for complacency, so I think that's well taken. Karen.
Thank you, Hein, and thank you, Jade. It's really a comment. We really shouldn't underestimate the efforts and hard work that's gone into Jade and her team in the and working with the different elements of primary care to achieve what she has. And I think we really need to note that and congratulate it, because we often fail to celebrate what we have achieved. Whilst it will never be 100% where we want it to actually be attracting dentists, to have 96% of our practices as training is phenomenal. It goes hand in hand with the research that we get through within primary care, which is phenomenal. And that makes us an more attractive place for people to want to come and work in Norfolk, because it is always about how clinicians can continue to work and to improve and to attract and retain and educate others. So it's a huge success. And I just want to thank Helen. It sounds like the Oscars, doesn't it? I want to thank Helen as well, because of the very solid progress that's been made. That's really good. Thank you. I'll stop now, Hein.
Thank you, Karen. Lauren.
I would also like to thank Helen in my Oscar speech of the support and the capacity that she's provided for pharmacists and their teams to develop themselves. I have to say, I really am concerned and quite astounded by the disparity that may open up over the next few months between the primary care workforce team and the continuing support for development of optometry, dental and GP retention capacity, CPD, etc., with the looming concern that there will not be much of a pharmacy workforce element going forward into the new ICB. I keep hearing rumours, and I don't want to assume, but that the pharmacy workforce is not a requirement of the future ICB, and I just wanted to question that and check whether we actually have any clarity over what the Norfolk and Suffolk joint offer for community pharmacy in particular and the wider pharmacy workforce will be in the new world.
Yeah, I'll leave to Mark when he wants to add anything, but there is no final structure yet of the organization, so I think there's one proviso I would say. But Mark, if there's anything you want to say at this point, but I know there's a level of uncertainty on what you can say, I guess.
Yeah, absolutely, and I can't speak for because in the new structure it's not proposed to be a part of my directorate. However, it's one that I'm very interested in because I want to make sure it has the right resources to be able to do the work going forward, Lauren. So the current position is the consultation closed on Monday Monday evening. We, over the next couple of weeks, are going to be reviewing that, and changes will be made to the structure. So it'd be difficult for me to prejudge, but I do know that concerns have been raised as formally as part of that consultation period, which is helpful. And we as an exec and as a team are looking at improving the structure that was put out for consultation beyond now. So watch this space, Lauren, but we've definitely heard that message. I know as a wider team, wider exec. Thanks.
Come to you in a moment, Michael, but Sadie, anything you want to add on this one?
If that's okay. I mean, I won't sort of comment on what Mark's just said, but what we do know, for example, is that the training hub contracts in Norfolk and Waveney and Suffolk and North East Essex both host the training hub contracts. Those are running. Jade will know the exact date, but I think longer than the original plan. And the reason for that is because nationally they are being reviewed, and we have been engaged with, as have all ICBs across the country, and the themes that are coming back from that are pretty consistent. And so if we bear in mind that when the training hub contracts were originally let, I don't think we had delegated commissioning at that stage. So we weren't responsible for commissioning community pharmacy, dentistry, optometry. So the training hub's only really focused on general practice roles. Now, obviously, there's been a big change nationally since then, and the feedback was pretty unanimous about wanting parity of esteem for all primary care contractor groups. So that is being fed into the national review, and at some point that will result in a national recommendation, which will then inform a procurement to replace the current training hub. So I'm keeping my fingers crossed that, you know, this will be partially addressed through training hub procurements, but as Mark said, we won't know what's happening very locally until we see that final version of the structure.
But your concern is noted, Lauren. Michael.
Yeah, I just want to say, I mean, it should go without saying, but I echo what Karen and Lauren have said about Helen and pharmacy workforce. And I do too have concerns about the direction of travel. The blueprint suggests that pharmacy workforce will be picked up by a provider, but which provider and when? And Mark, my equivalent in Suffolk, and I firmly believe if nobody's actually going to be picking it up, then it should stay with us until somebody does pick it up, because it's a big risk. We can't, get our work done if we aren't enabling pharmacy workforce in a strategic manner, so that we have at least some sort of handle on it. It's just, it's a big risk, and I think the regional team are only just getting to grips with that and thinking about where it sits. Literally had an email today about that.
Okay.
I'll shut up.
Michael. That's a really good note and update. I had a sort of mundane question. Maybe we can pick it up offline, Jade, but I like the dashboard, sort of the pictorials, but it's interesting when I look at the GP workforce spread, it's fairly even across the 5 places in Norfolk and Waveney, but in dentistry, it's much more biased. And is there a simple reason for it? Is this how the geography of the practices, how they fall in the various places, or is there another reason to it?
No, it's purely where the NHS contracts are held. And
Okay.
obviously the workforce is picked from that. So very be a high lens towards Great Yarmouth and Waveney, because we have and obviously Norwich, but in other areas such as South Norfolk and West Norfolk, the activity of NHS practices is reduced. So that's why you've got the inequity.
Yeah. I hadn't sort of clocked it yet, but good to see. Right. I see no further hands up. There's some recommendations listed in the note. Jade alluded to it, to approve the updated risk assessment, which also means as they reach target risk scores, they can sort of go to a lower level of monitoring. So I just want to check committee's happy with that, then of course note the great progress that has been made. So many thanks, Jade and Helm, for bringing that to us. That takes us to item 11, delivery group reports. We'll start with GP Community Pharmacy Delivery Group. Shepard, will you introduce that?
Yes, thank you. I probably won't take long on this. We had really good broad range of items discussed at the December meeting. I will just highlight a few from that. We looked at the risks. We spent a lot of time talking about the approach around the risk and discussed the workforce risk, which you've had, and we made those recommendations that it comes to this place. So that is now addressed already. We spent also a good time looking at the integrated performance report. I think this is one of the items that was recommended through PCCC, and we are continuously strengthening our discussions around that. And within that, I think the report showed that we are heading in the right direction across general practice and community pharmacy in terms of the activity, so which is really good. So we also had some detailed reports around prescribing, and it was really good to see that we are making some improvements in terms of some of the culture around prescribing of antibiotics, but still more work we need to continue to do in those spaces. We also had good discussion around where we are at regarding the new contracts and compliance, which is really good, and to focus on how we are doing, and we are doing really well in that space. And I think there were also chair's action on estates, which was really noted, and good to have that. And the final, I think, report was, of course, around the finances, which showed that we were under performing, which is really good because it does take a little bit of pressure from us, but it also creates opportunities for us to think about how to strengthen resilience in our system and also focus on the health inequalities and stuff. So really good meeting discussion points with just well attended. I think that's how far I could go with this, unless if other colleagues or Sharon is here, if I've missed anything that colleagues wants to show off from that, but a well-established meeting.
Good. Let me see this question or comments. It's here for noting. Not many thanks. There's two reports for the Dental Service Delivery Group and the Dental Development Group. So Fiona, I can ask you to pick out the highlights.
Thank you. So first of all, Dental Services Delivery Group, which is the decision-making group out of the two. You can see that there was a broad range of topics discussed and a number of items receiving approval from the delivery group. I guess the highlights I would like to bring out are the fact that we're now starting to take a much more robust approach to underperformance, looking to rebase contracts and use the money to reinvest with providers or in new contracts to support access. Those discussions with providers are actually being very productive, and they're resulting in a number of contractual changes coming through. And the other area I'd like to highlight is the unscheduled care performance, and the utilisation of appointments is around 96–97%. Although we are starting to see a small increase in the number of appointments which are not being used, and most of those are actually in Norwich and Kings Lynn. So we're trying to understand the data and why that's happening when clearly there's a demand for urgent care. But I will stop there on that one. Happy to take any questions. Or I can move straight on to the dental
If you
development.
move straight on, and then we'll see if there's any questions overall. Yeah.
This group is made up of a wide range of key stakeholders and the dental profession, and it's used to help us inform our commissioning plans going forward. The group received reports, really update reports and progress on a number of pathways that we've introduced. And I think probably to highlight really going forward, we're going to be looking to work with Suffolk and to develop a joint plan going forward. So obviously we will want to look at the role of this group in the future and where it fits in with the governance.
Thank you, Fiona. Any questions or comments for Fiona on either report? No, all straightforward, and I was here for noting. Many thanks, Fiona. That takes us to item 12, the final outcome report of an interesting project. And Sharon, I think you will introduce that.
Yeah, thank you, Hein. I will take the paper as read, but just to give a brief summary of the key points. So the report discusses the final summary of the pharmacy integration project, which was a joint initiative with SNE ICB. And through a procurement process, Community Pharmacy Norfolk and Suffolk were chosen as the provider. The main aim of the project was to strengthen the integration of community pharmacy within the local NHS systems, mainly reviewing referral pathways from not only primary care providers into the now established Pharmacy First services, but also from the acute trust through the discharge medicine service. Key findings, Pharmacy First services, we had a really strong engagement and significant growth across both ICBs, with the contraception service showing the biggest growth. Norfolk and Waveney also saw the highest regional growth for contraception across the year. Public awareness of the service was key, and this grew through targeted promotions and supported an increase in patients self-referring to the service. Also, an ICB friends and family test, which was launched during the project to date, has shown 100% satisfaction in the service, and this feedback has been shared with contractors. In regards to DMS, it highlighted variability in readiness of each of the acute trusts, and also highlighted workforce capacity within their trust restricted referrals. This service is dependent on referrals from the hospital, but work was also conducted with the pharmacies to ensure that when a referral is received, they are actioned within the appropriate timescales. DMS does fall within the medium-term planning framework, so as a key action, this will continue to be a focus for the ICB. Training and engagement, there was a series of webinars, face-to-face events, and also digital resources were produced, and that saw over 300 pharmacy professionals being supported. Also, during the project, we recognised the expansion of the Pharmacy First service to the use of technicians. So there is a new focus which now concentrates on the engagement with the wider pharmacy team, and we do actually have a technician training event planned for in a couple of weeks' time. So in conclusion, I believe the project has laid some strong foundations on what future strategic commissioning could look like. And as we evolve into that role, learnings from this project can be reviewed. A key priority that's been agreed is to maintain a shared understanding of the community pharmacy role and system delivery between Community Pharmacy Norfolk and Suffolk and both ICBs. Integration of pharmacy within primary care remains a key enabler for future clinical services and should remain a key focus that, combined with national developments around digital integration, should see improvements. Happy to take any questions. I will also, as Lauren is here, I don't know whether Lauren would also like to share her findings of the project as the provider.
I was gonna ask Lauren if she wants to add something at this stage before we open up for questions coming.
Thank you, Sharon. I do think this was a really key piece of strategic commissioning, probably sort of before its time, to be honest. You know, the fact that this was planned and implemented before we knew what was coming down the road. But I have to say, stepping outside of our representative role and having the funding, the capacity and the ability to look at things like social media boosting, look at enhanced feedback, access to data, all the wider things that we usually are not able to get involved in, really did open our eyes to not only the opportunities, but some of the barriers that require sort of sustained attention and support in the future. I know that the future ICB isn't going to be a support function, but it is going to obviously have a commissioning role. And I would certainly say that if there is a desire to increase the capacity and the robustness of community pharmacy services and their impact on patient outcomes, DMS in particular is one that needs to be tackled with secondary care, around getting patients from secondary care into the community and keeping them there rather than them bouncing back. And in terms of the peak up services, so things around hypertension, contraception and pharmacy first, we've got not just pharmacists in community pharmacies, we've got whole teams that can be involved in that care. And the more we can do to increase the capacity, the confidence and the utilisation of the full team and estates that we have available in deprived areas, I think the greater outcomes we can have for patients. So I would ask, if you don't get a chance to read all 27 pages of that report, please do have a look at the recommendations at the end, because I think there's quite a lot that can be done at a system level, certainly around data sharing agreements and recognition of models that work. Even if a future project like this isn't commissioned, there are some quite strong recommendations in there that could have an impact in the future.
Thank you. So wrap up for questions and comments. And one that I had, so how is this report shared, or rather the narrative behind it? Because I think there's some really recommendations, insights that would benefit a larger group of people to see this, and I mean a group of people in decision-making authority. So is anything planned, or how can we amplify some of these findings and insights? Who wants to take that question?
There wasn't necessarily anything planned, but I think actually as we evolve and move forward and we move into that space of strategic commissioning, I think there is an element of, we were maybe a little bit ahead of the game with this particular project, and actually the whole commissioning at a scale perspective is actually this project has really highlighted how that can work very, very well. So I think there isn't necessarily any plans to share wider, but it's a good challenge, Hein, and something that we maybe need to take away and consider. But I do think there's learnings from this project that can be, as you say, be benefit to other people, and you know, the sharing of that with a wider team is probably going to be of benefit.
Yep. Sadie?
I mean, as we've touched on in the Director of Primary Care report, and will be in the strategic primary care framework, one of the things we're really keen to see is providers coming together in a collaborative way, and that's slightly different to some of the things that we've got in place around kind of representative committees at the moment. It was really interesting hearing Lauren talk about going beyond the representative role, because I think that is really important in the future, and I think as strategic commissioners that's what we need from our primary care providers, that you know, they can come together collaboratively so that they can act as a partner, a single partner effectively in our system, because we know that there are an awful lot of independent contractors and it's not easy to engage. So I think this piece of work that you have delivered collaboratively across Norfolk and Suffolk is something that we can really sort of learn from as we move forward and look to the future around sort of primary care partnership working, collaborative working. I mean, Hein and I are meeting later because we will be reporting to the board, so this may be one of the areas that we want to pick up on in that report to the board, because I absolutely agree. it's really great to see. And isn't it great that we did it across Norfolk and Suffolk before we even knew that we were going to be coming together as Norfolk and Suffolk? So it's very, very valuable piece of work for looking forward. Thank you.
Yeah, no, we should definitely include it in the chair report, Sadie. The other one, it's maybe a bit technical, but it's in your recommendations in the report, that this lack of interoperability, I think you alluded to it, and you said that would be something for medium term, 6 to 18 months. Is this a quite focused piece of work, or do you need to engage with many contractors, many estates? Can you give me a sense on the type of effort needed to overcome what seems to be a clear barrier at the moment, Lauren?
Yep. So I think this is a piece of work on it, that has actually quite wide implications. Obviously, I've mentioned pharmacy first and discharge medicine service workflows, but I think there's work to be done about understanding the existing IT systems and how referrals are made and received, both from secondary care to pharmacy, from GP, from NHS 111 to pharmacy, and obviously how information flows back and making sure that we've got the feedback loop fully understood. But it's trying to understand whether what we have in place is fit for purpose but not being used correctly, whether there are licensing requirements. That's something we certainly came across at some of the secondary care trusts, and also whether GP systems, the enhancements to GP Connect, etc., whether the problem is actually solved and just not being used and there's a training piece of work to be done, or whether there's further work needed to try and encourage the IT providers to solve the specific issues. So I think there are the reason why it's in the sort of medium term is there's a piece of work to understand what the issue is, work out whether there is already a solution in place, or whether we need to push for a solution to be developed. But I think until we get the right systems available to the people delivering the patient care, there's always going to be a bit of extra workload and confusion, and potentially not utilising the best services for the patients due to fear of governance and duplication of work and not being able to close that feedback loop. So, for example, for pharmacies, it would be fantastic to know that if we do have to escalate somebody after a pharmacy first intervention, what actually happened to that patient? Is there a note to say, thank you, this patient has been resolved, dealt with, what was the outcome? But also with things like the discharge medicine service, we know from data that the return on investment on avoiding bed days for patients that get discharge medicines information shared with their pharmacy is very, very significant. But we don't actually have the local data around what our interventions mean for our patients. And if we had better systems and interoperability in place, we might be able to track that patient journey and understand what the value of that has been. Yeah. So it's quite a wide piece of work, but that's why it's in the medium. Because we don't know how big it is until we start exploring it.
Yeah, very helpful. I see no further hands up, so the paper is here for noting, but I think some real positive takeaways from it. So many thanks, Sharon and Lauren. Takes us to item 13, strategic framework for primary care. There's a lot happening there. Amanda, I'll hand over to you.
Thank you again, Hein. So it's probably useful to acknowledge that we received some feedback from the LMC at lunchtime today. So thanks to colleagues for that. Given the timing, I hope it's okay that we can pick these points up outside of the meeting to ensure that these are given the detailed attention that they deserve. So that's my first point. Throughout the paper, people will see that there is a focus on primary care becoming a unified and credible partner. And I thought it might be helpful to be absolutely clear that that language is not a criticism of any of our current providers, and it is not an implication that anybody is failing to deliver on their current contract or obligations. Rather, The phrasing reflects, I think, a recognition that has been building across our system for about the last 12 months, possibly longer, that while primary care providers deliver excellent work operationally, there is a space at the system leadership level where we believe, and our system partners believe, that more integrated collective input from primary care would be really beneficial in the wider strategic planning space. So that's just to hopefully be clear on that one. Finally, the progress in the 4 areas that were kind of picked out under the strategic framework when it was adopted last year are very rarely linear. They're complex, they've got huge amounts of interdependencies, and because of this, rather than creating a standalone sort of work stream or work program, we have intentionally looked to embed these in existing work programs to ensure that they complement and hopefully sustain the efforts in those work programs. So I think that's all I really wanted to pull out on that, but really welcome any feedback for me to take to consider as we move forward on these areas.
Good, thanks, Amanda. Ian.
Thanks, Hein. Thanks, Amanda. Yeah, your comments are noted. Absolutely understand it's better to, given the time frame, to look at this outside this meeting. Just an immediate comment on your thoughts about the profile of general practice within whole system. Ultimately, yes, there is a very well and developed ideal that general practice will be involved. I mean, we go back to CCGs created back in 2012, I think it was. General practice wants to play its part in the system, but it doesn't have the huge resources of the acutes, doesn't have teams of contract managers or whatever. And that's the fundamental difference, that we are talking of 103 different small practices, different small businesses across Norfolk and Waveney. So you know that the GP collaborative is moving ahead. Hopefully there will be further developments both this month and next. And yes, it would be great to work with whole system partners. You'll be aware of the direct meetings held at Quadrum Institute with NNUH. And ultimately, there's been a lot of good stuff, but there are some fundamental differences. The wider system needs to acknowledge that general practice can only get involved when there is the appropriate time, funding, etc. to do so, because they don't have teams of employed contract teams or business development teams such as the hospitals have. So just make that point, but really welcome your earlier comments and work with the ICB going forward. Thank you.
Thanks, Ian. Any other questions or comments? No, I think it's one of the topics, Amanda, that sort of keep coming back to this committee. It will be in a sort of a new organizational setting, but I think, as you say, there's a lot happening, so good sort of keep finger on the pulse as committee. But no further hands, and it was here for noting, so many thanks for bringing it to it, and good to note you will address the points LMC put forward offline. That takes us to item 14, the strategic prescribing report. Michael, can I invite you to introduce?
Thanks, Hein. I'll take the paper as read. A lot of information in there, so I'll perhaps take questions as well. I'll just highlight a few things, get you some time back. On the subject of AMR, there's the 3 new indicators which we're still getting to grips with, as opposed to the 2 old national indicators which we're still monitoring. But percentage of children 0 to 9 with 1 antibiotic in primary care in the last 12 months, target's below 27%. A year ago, it was 40.3%. i.e. above the target. This year, the latest data we got in October, 29.8. So we're tantalisingly close to the aspirational, slightly arbitrary national target of 27%, but it's that's good, and we're working with some partners, as you'll see, within the data, particularly the walk-in centre, to establish what we know to be the case, certainly with walk-in centres, that they're going to be seeing more children for obvious reasons. And then the second indicator, watch and reserve antibiotics. So choice should be 70% or above, and we're 81.7%, which is the highest in the east of England. So we're doing great on that. There's more work to do on the length of antibiotics. We've still got some clinicians who don't know that the national indication around length of antibiotics has reduced to 5 days and are still almost exclusively prescribing 7 days, and we are working with those colleagues to try and get that changed. There are some factors there which are particularly dispensing practices who anyway, not go there. Skewing the data, shall we say. We did win, as you're seeing there, we did win an award in the Norfolk Fire and Rescue Awards, which I didn't know was a thing, but we've done a lot of work. There was a few deaths, particularly in the West, in the last few years around paraffin-based emollients causing patients actually, setting fire to themselves accidentally because of the build-up of residue. So well done to the team for that. The only other thing I wanted to mention was some unwelcome developments with the NHS app, which is on the whole a welcome thing, but it was discovered and wasn't known by pharmacy leaders nationally that the NHS app has introduced a button which says order all on your repeats, which is sounds on the face of it to be a good thing, but a lot of repeats are actually occasional repeats, things like paracetamol or GTN sprays, for instance, which is the case with my dad, who has a suitcase full of paracetamol, which I'm slowly weaning him off of, because if you order everything every month, that's what happens. And the flip side of that is that if you think you're ordering everything, the NHS app has and clinical systems has a feature that if you're out of repeats, what happens is that it just disappears off of your repeats with no explanation. There's no placeholder saying this would be your repeat, but you can't order it until you've seen the relevant clinician, or you have to have your blood test. So what that will mean is patients will go into pharmacies and GP practices and be very unhappy that they haven't got all of their medicines, because they will say with some degree of certainty, well, I clicked order all, and it's your fault I haven't got all of my medicine. So it's a recipe for conflict and waste, and is on the face of it useful, but it's actually unwelcome and unhelpful. So we have escalated that, and we'd welcome you to do the same if you have the opportunity. Comments welcomed.
Yeah, I was going to ask you about this NHS thing, but you beat me to it. So
okay,
let's see your point you're making. Any questions or comments from Michael? See no hands up. Very informative as always. Well done on the awards. I had not appreciated this was a particular risk area, so well done to the team. We'll move to the last item before AOB on the agenda, last but not least, strategic finance report. James, can I hand over to you?
Yeah, thank you, Hein. As I'll take the paper as read and just highlight some of the key financial points from it. So we are currently £2.4 million underspent for the Primary Care and Prescribing Directorate of a total budget of £629.3 million. This is approximately a £400,000 additional underspend from the month 7 position to the month 8 position. The areas that's creating underspend are relatively the same as last month. So GP prescribing, locally commissioned services, DPC, Optom, pharmacy. These are all inclusive of the planned efficiencies, which are also offsetting those. There is an additional cost within that, which is within the GPIT area, some stranded costs, which we reported also last month. It's worth noting that that position is doesn't have any in-year dental performance adjustments. That's due to be adjusted next month in the month 9 position. So that's not included in the 2.4 that we're reporting so far overall. The rest of the pack has the usual items, so the efficiencies which are showing on plan and the LCS utilisation as well, and then a detailed subdirectorate analysis of each of the areas. So that's all I was going to point out if there are any questions.
Thank you, James. Sounds like next month will be the one to watch on the dental side. So see the report. And any questions for James on the report? No hands up. So many thanks, James, for the report. Last item, any other business from anyone? No, so many thanks for joining part 1. For those joining part 2, we'll reconvene. There's a separate link in 10 minutes, 3:45. I'll probably see many of you there. Thanks for joining today. See you, most of you, pretty soon. Bye.
Thank you.